Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. Welcome to another episode. Today I'm with Dr. Michael DeLuke. He's an orthodontist stationed in Florida. Michael, thank you so much for joining us back on the podcast.
Yeah, thanks for having me back on, Grant. Appreciate it.
Yeah. So today last time we focused on some kind of financial type stuff, setting yourself up for success and being able to kind of put yourself in a position to do what you want to do and achieve goals. Today we were going to do more of a clinical topic and just talk a little bit about orthodontics and surgery and how they can help with airway issues. Can you kind of kick us off on some of your thoughts on this topic?
Sure. So I became passionate about this a little bit into my career. It was not at first. Didn't get a lot of this training in terms of understanding and looking at airway in my residency. Most don't. I mean, this is going back to the early 2000s. And even today, though, sadly, a lot of residents in the orthodontic arena are not getting this. And I was treating cases as I was starting to progress through my practice. And as we talked about in the last show, I started my own practice from scratch. I'd never had anybody that I worked for or with. So I was able to do what I wanted to do. And when I wanted to try something new or do something different, I was able to do that. And I just started looking at my cases at a young age. And we're taught mostly in orthodontics that when you see a patient at 6, 7 years of age, which I now believe you can go in and do things even younger in some cases, but let's just say that for now, we're taught it should be a question of whether the teeth fit in. And that really should be what you're trying to figure out. Like, can I fit the teeth into this patient? And that's what you tend to base your decision. Yes, if there's a cross bite or something, open bite, you might have a little more involvement. But if you just get a patient who's crowded teeth, it's this decision of, well, can I wait or should I do something now or can I just wait? And that's where a lot of our literature is as well. A lot of the articles, especially in the 90s and early 2000s, guys like Gianelli and Tunkay, they were Little and Rydell. They were really putting these studies out to talk about reasons why you can wait and you can kind of time this in the late mixed dentition to fit the teeth in. But if you look at those studies, they're all about, and the studies that say that phase 1 doesn't have a benefit or there's no real advantage. Honestly, Grant, I don't think any of them mention airway that I've found, like, at all. They're not discussing that. They're not discussing the fact that they might have a transverse deficiency in the absence of a posterior crossbite. There's one study by McNamara with Bichetti and Frankie in 2006 in AJODO. They go into it in detail and they talk about the advantages of that. There's another one by Hune and colleagues in 2009. And so you start to see this in that time period. But prior to that, you weren't seeing a lot of studies on anything about even expanding the lower. It was all about, if they don't have a posterior crossbite, you don't expand. And that's still the dogma in the vast majority of orthodontic education programs today. As especially your audience in the surgery arena, those who are in the surgery arena know, many of these patients you're seeing later on, even if they don't have a transverse crossbite, they have a transverse deficiency. They have a narrow mandibular arch and a narrow maxilla. And so I started realizing this young and saying, gosh, these kids coming in at like 7 years old, yeah, they're crowded. Yeah, their laterals don't have room to grow in. But why am I going to start pulling teeth on this patient? I mean, it's almost never macrodontia. And we've known there's a study going back to 1964 that Mills did looking at this, saying it was not the size of the teeth. It was the size of the jaws that resulted in crowding. And McNamara did another study with O'Connor and Howe published in 83 in the AJO. And that one looked at 104 patients, half had crowding, half didn't. And they concluded the crowding was essentially always due to narrow arches, deficient arch width, not large teeth. So I started looking at these cases like, why am I solving this with a tooth removal solution? I'm not treating the etiology. I'm literally treating the symptom. I'm just like, teeth don't have room, jaws are small. Oh, well, what do? I was taught you can't expand a lower arch, and that you don't expand in the absence of a posterior crossbite. So guess we got to pull teeth. And early in my career, I'm thinking, I don't accept this. So I started doing more research, looking into the literature, realized that Schwartz and Gratz studies in the 60s on expanding the mandibular arch, and that this has been done for many decades and is stable. And so when I say that at first, some of your audience might think, well, you can't expand the mandible without surgery. The mandibular symphysis is fused around birth. Exactly. You're not, in these cases, expanding the mandible. You're uprighting the mandibular teeth and getting dental alveolar expansion. If you think about it, think of a coronal slice of a CBCT and look at that curve of Wilson in that lower arch. And it's so steep. And as you guys placing implants know, right? That's a nightmare for you. When you have to place this implant, the thing is cantilevered out over the bone. The forces are not directed along the long axis. Well, that's a patient that might not have a crossbite, but they have a transverse deficiency. And in many cases, the restorative dentist, you'll restore that tooth into crossbite because the forces on the implant will be better, more vertically directed. So it's not complicated in concept, but for some reason in the orthodontic profession, it is still so dogmatic that you don't expand in the absence of a posterior crossbite. So I just started challenging it. And I said, looked at the parents and I said, well, we can pull some teeth. And parents were like, well, I don't really want to do that if I don't have to. I said, well, all right, well, let's just try to help the patient grow. And so I would go in and put a lower expander in and try to slowly, you're not turning this thing once or twice a day, you turn it once a week and you get nice dental alveolar uprighting. And then when I would get that curve of Wilson flat, I would go to the upper, and you have a posterior crossbite bilaterally now, and you expand the upper, and lo and behold, no crowding. These patients have room for all their adult teeth. They're doing great. So finish this up, but it's a lot of work. It's a lot of heavy lifting because you're in there with these big appliances, and there's behavioral challenges with the speech and swallowing, and a lot of these patients have lack of tongue space already. So there were some challenges, but I still felt this was better for my patients. Then I started getting asked by parents, Dr. Mike, do you think the fact that Johnny's not snoring anymore, do you think that's something to do with the expansion? And I'm kind of embarrassed to say, this is going back 20 years ago, I didn't know. And I was like, well, maybe. I mean, I guess it certainly couldn't hurt. We're making more room, and the roof of the mouth is the floor of the nose. So it certainly could. So I started getting asked about it enough that I started looking into it. And I realized there's some literature out there, a good amount, even at that point, that started to talk about this. So then when it really accelerated was when I got my cone beam, my CBCT, I had a low dose CBCT in 2014. And that really started to change everything. And then I'm looking at these coronal slices of these images. I'm starting to understand, I'm looking through the airway. I'm seeing the nasal passageways. I'm seeing the pharyngeal airway. I'm noticing turbinate hypertrophy and nasal passageway obstruction. I'm noticing hypertrophied adenoids and tonsils, looking at my whole patient now, looking at their eyes, their craniofacial growth, how the face is growing in light of the airway, and starting to figure out, oh my goodness, a lot of these patients that are very narrow and growing this way, they can't breathe through their nose, and they're becoming obligate mouth breathers at a young age. And it's creating this craniofacial dysmorphism that is causing them to literally morph into these adenoid facies type patients. And it's really interesting because in my profession, I've got a lot of colleagues, my ortho colleagues, who will say, it's all genetic. There's no environmental influence. And I'll say, so you don't believe that adenoid facies is a thing? And I'll say, well, yes, but that's very isolated. And I always say, you can't have it both ways. Like, it's either a thing or it's not a thing. Either the environment can influence it or it can't. Adenoid facies was a term coined in 1872 by Wilhelm Meyer. It's not a new concept. It's been around for 150 years. So we've known for a very long time that if we don't breathe through our nose and become obligate mouth breathers, that it changes the way our face develops. Harvold had his studies throughout the 70s on that were phenomenal with his purebred rhesus monkeys. And Linda Aronson talked a lot about this. I mean, there's so much data that the way we breathe changes the way and the shape of the face, the way the face grows in the shape of the face. So I started putting all this together and realizing, if I detect this young in these kids, get them to the allergist, get them to the ENT if and when needed, and then I go in and normalize their anatomy intraorally by expanding them, which I now do with braces and wires in the younger kids. I actually got away from even using turnkey expanders, which is a whole nother topic. But if you go in and develop these arches in a transverse dimension, you literally transform these patients' lives. And you watch right in front of you, these patients go from being open mouth, breathing, sleeping poorly, having ADHD, signs and symptoms of ADHD, all sorts of behavioral issues, socialization issues. And when you figure out if it is an airway problem and then address the anatomy to normalize it with your medical colleagues as needed, and then you can incorporate more myofunctional therapy as well, which can be a huge adjunct, you transform these kids' lives. And that really was what started to happen time and time and time again. And then on the surgical side, the reason why I don't understand why this is controversial is we know, you guys know much better than me, a large number of these patients that you're doing MMAs on, or I mean, what are you trying to do in these patients who have obstructive sleep apnea? You're expanding and pulling the maxillomandible forward, right? You're trying to get them to be more prognathic, so to speak, to have a more fuller mid-face and lower third of the face, and develop the transverse. And in some combination thereof, everybody's got their own sort of approach to that. So when I talk to my ortho colleagues who say we shouldn't be helping them try to do this young, I'm like, so we just wait and let it be a surgical, let them suffer for however many decades of their life. They're going to suffer, not just from a craniofacial growth standpoint, but now we know from the medical literature, tons of medical literature talking about, I mean, even the fact that some of these patients who have, there's been studies to show they have decreases in gray matter. I mean, they actually can, there was one, I think it was the one, Isaiah and colleagues in 2021, talking about those who snored or even gasped during sleep, had looked at over 10,000 MRIs, that those patients had smaller amounts of gray matter in their frontal lobes. So this is big. This is big stuff. And so you guys have to go in and clean up, unfortunately, a lot of our errors in diagnosis on these patients who we could have detected this stuff on earlier and gotten these patients more proactive, as we left off last time talking about Peter Attia and the concept of being more proactive in our approach to our healthcare. Orthodontists are just, I don't want to make it like I'm disparaging my profession or my colleagues. I love what I do. I love my orthodontic colleagues. I make the analogy of it's like when you love a family member, but you have to kind of have tough love sometimes and call them out. And that's what I feel like I'm doing to my profession is, hey, guys and gals, we are better and can do better than just relegating ourselves to two straighteners who just try to clean up and straighten the teeth the best we can in teenagers or adults. We can be better than that.
Wow. Yeah, that's amazing. So I mean, are you thinking that most of this is occurring, the adenoid facies is occurring due to enlarged adenoids and blocking nasal airflow, and then growth is restricted and et cetera? Is that where it all begins, or what is your thought?
Yeah, it's interesting because it can be multifactorial. I just did a virtual consult with a resident, actually at another residency, not the one at Nova that I teach at, because I help a lot of residents around the country on this. And it was a patient who, let me back that up. Unfortunately, we're not teaching in the orthodontic arena how to get to know our patients better and ask the right questions to figure out why that's happening. So we're looking at the mouth, we're looking at the malocclusion, and we're hyper focused on that. So we sit down and we're so quick to say like they're class 1 or they're a little class 2 or they have an open bite, and we don't really look at the face enough. We might look at it in our records and just, are there asymmetries, or how are their thirds, or their vertical thirds and fifths, but ultimately we're not looking at them critically to look at things like allergic shiners, right? Benny Morgan lines, which are a sign of atopy. Those are those wrinkles you get underneath the eyes that you'll see in some young kids. Allergic crease in the bridge of the nose from that allergic salute that they call it when the kids are, sniffling and pushing their nose up all the time. So chapped lips, what I call chapped gums, which are those thick hyperplastic anterior gingiva you see in these young kids. Higher caries risk, caked on plaque, all of these signs that this patient is mouth breathing. Now, what causes that, to your question, can be very different in different patients. So this consult I was doing with this resident, they had a cone beam, which was awesome. And I looked through it, and interestingly, a little bit, there's some underdevelopment of the sinuses, some maxillary sinus hypoplasia, especially on the left side. A little bit of turbinate hypertrophy maybe on the left side, but certainly not obstructive. Nothing, I was actually anticipating it to be much worse. I mean, this girl is the classic poster child for adenoid face. If you look at what it looks like, long vertical grower, transverse deficient, auto rotation of the mandible downward and backward, dark circles under her eyes, excessive scleral show on the inferior border of the eyes because the droop. So you start to see all this and you're going, hey, this girl's got to be obstructed somehow. Well, he looks through the cone beam. Nasal passageways aren't that bad. Get up to the adenoids, and there's not much there. It actually had the appearance of a patient who had an adenoidectomy. So I said to him, but again, we're just not teaching residents to get this history. So I said, I guarantee this girl had her adenoids out. I've seen so many of these. I could be wrong, but I would be willing to bet. So ask mom, ask mom if she had her adenoids out, because the airway didn't seem obstructive enough. Now, the other part of that is she didn't have enough tongue space. So her tongue, when you look at the coronal slice, couldn't even come close to fitting into her palate, and not even close. So she's got this high vaulted palate, which if she was mouth breathing, we know can lead to that no matter what the cause of the mouth breathing was. And now her tongue is positioned very posteriorly, even just sitting upright in a cone beam, the oropharyngeal airway space was very narrow and compressed. So you imagine when that child lies down at night, she had like 10 millimeters overjet. There's no way she's establishing lip competence and lip seal. She's absolutely going to be a mouth breather, and probably snore as well. So it's obviously multifactorial. There are a lot of things causing this to happen, but there's some obstruction somewhere at some point causing them to not be able to breathe through the nose in the majority of these cases. I mean, central sleep apnea in kids is rare, very rare. I mean, it's not that it can't happen, but it's not typical. It's usually obstructive for some reason or another. But then when those arches are so narrow and that tongue has no space, the tongue can do the obstructing at that point. And that's why we get so caught up in our literature of, adenotonsillectomy is the gold standard to treat pediatric obstructive sleep apnea, which we could have a whole conversation on pediatric OSA anyway. But and I say, it's better than expansion. Or I look at people like, what? That is just irrelevant, honestly, because each patient is different. In one patient, it may work. And in another patient, it may not. And so let's say this patient that I was talking about had her tonsils and adenoids out, or at least her adenoids looked like she had a little tonsillar tissue still. It didn't work for her. So, I would have patients come into my practice all the time and say that, they had their tonsils or adenoids out a year ago and it seemed to be better for a while. And then they start snoring again. They start mouth breathing again. So there's something else causing it. And if those patients grew with that adenoid facies face, that narrow, vertical, narrow face, and lack of high vaulted palate, insufficient tongue space, sometimes just the tongue can be doing the obstructing at that point because it can't fit up into the palate. Last thing on that is Bhattacharya had a study in 2010, American Journal, Respiratory and Critical Care Medicine, looked at, it was 578 patients, children, 8 sleep centers across the US and Europe. Only 27% of those patients who had adenotonsillectomy had complete resolution of their symptoms. I think it was up to like within 30 months of the procedure being done. So we know that adenotonsillectomy doesn't solve it all the time. So to your question, maybe, but let's say that patient had allergic rhinitis, right? Allergic rhinitis has an extremely high prevalence in young children. The American Institute for Allergy and Asthma estimates that 40% of all children suffer from allergic rhinitis. And of those, some studies show that as many as 81% can have turbinate hypertrophy. So they might get the tonsils and adenoids out, but they might have obstruction of their nasal passageways. So they still can't breathe through their nose. They're still now mouth breathers and they're changing the way the face grows. So what I encourage when I teach and what I encourage people to do is just look for more than just the teeth. Look at these patients. And on the surgery side, I would encourage the surgeons, I know it's tough because there's the political side of this, but when you're getting patients sent to you to pull buys on some of these younger kids and start them down a serial exopath, some questions. Is it really because this kid has big teeth? And really, if they have broad jaws and protrusive and bimax and really wide, and they're still crowded, you'll almost see that as I'm describing that, everyone's probably going, well, I don't think I've ever seen that. It's rare to see that. It happens, but it's very rare. Well, then maybe you need to remove some tooth mass. Other than that, and again, I had cases like that in my career where they were broad and they just had bigger teeth and they were full. And it was like, we need to get some teeth out of here. That is so the exception. The vast majority of these patients are transverse deficient, midface deficient, or both. And they are solving a skeletal imbalance, a craniofacial dysmorphism, with a tooth solution. And I would really encourage the surgeons out there, your surgical colleagues, to just ask some questions of your orthodontists. Question them. They need to give you a defense of why they're not helping this patient grow at a younger age. And again, I want to clarify, it's not like if this patient's 25 years old and there's no room and they don't want to go through a surgical procedure or a SARPI or a MARPI or something. Obviously, you're going to have to make certain compromises. But if you have a young growing patient at 6, 7, 8 years old, you start sending them down a serial extraction pattern and this patient is narrow and can't breathe through their nose, that orthodontist needs to be questioned as to why they're taking that approach.
Yeah, I love that. I love what you're talking about, looking at the various causes of potential obstruction, the adenoids, the turbinates, the constriction of the jaws. All that stuff is so important to be taken into account. So let's say that you miss all that and you just say, okay, let's extract the bis and straighten the teeth. You do that. Is there evidence that removing teeth can cause further airway issues?
So happy you asked that question. So there's a study by, I believe, Larson in 2015. It's actually a very poor study. They looked at, it was like 1,000 patients, and still was, I think it was like a 12% difference in those who all had 4x and whether or not these patients had obstructive sleep apnea later in life. Now, the first part about that we need to clarify is what's obstructive sleep apnea? So a patient could still be suffering from sleep disordered breathing or have a sleep related breathing disorder, which is a spectrum of disease from primary snoring to OSA. So you have primary snoring, you have upper airway resistance syndrome, you have obstructive hypoventilation, and then you have the end stage of OSA. And along that spectrum, there's a different level of severity. So you could have a patient who has upper airway resistance syndrome, and you might send them for a sleep study. And in polysomnography, they may come back as not having AHI, an AHI that qualifies them as having even mild sleep apnea, right? Let alone moderate severe. Jerry Simmons, who was on my podcast recently, he's an amazing sleep physician out of Texas. He has people go in for PEZ. It's this esophageal monitor sensor he puts in these patients to kind of uncover this hidden occult obstruction that's not being picked up by polysomnography. And Jerry, in the episode he was on, made it very clear, especially in children, just to back up for a second on that, polysomnography is very unreliable, especially you send a kid to one night in a sleep lab. Not all sleep labs have the same standard. There's no standardization across the industry. Not all techs are trained the same way. Not all physicians read the results the same way. Not all of them are checking for RERAs and body movements. And so my profession loves to hold on to, well, if this child doesn't have an AHI of one or more, then they are fine. And that is not, if you read the medical sleep literature, that is far from the truth. Or if you talk to a pediatric ENT or a pediatric sleep physician, they will quickly tell you that's not the case. As far as when you then say remove the teeth. So again, let's just go with the fact that we are able to detect in some degree if this patient has a sleep issue that is registering on the apnea-hypopnea index. Okay, for a child, again, that would be one episode is enough. In 2007, American Academy of Sleep Medicine added that it can be an apnea or hypopnea for 2 successive breaths. Gets into the fact that because children have more rapid respiratory rates, the whole 10, because otherwise apnea or hypopnea has to last for 10 or greater seconds. And you're just rarely going to see that in children, which is why the childhood scale is essentially a third of the adult scale. So it's really important everyone understands that. Christian Gimeno, who created this index in the 70s, I know well people who, and have been on my show, who trained under him and knew him. And he said creating the pediatric AHI scale was one of his biggest regrets, because it created this false sense that if a child doesn't have an AHI score of 1 or greater, then the kid is okay and has no sleep issue. So to your point of that patient who gets 4 buys out as a early, so like 12, 13-year-old kid, an adolescent, we might not realize that they have that sleep issue, right? They might, if we send them for a sleep study, they might come back okay. They might still be having all these other issues. They might be having changes that are not registering them as diagnosable with obstructive sleep apnea, but they could have a sleep-related breathing disorder, which we know the comorbidities associated with both behaviorally, neurocognitively, and in their craniofacial growth and development are significant. So again, we're not addressing the etiology, we're treating the symptom. I say all the time, pulling teeth does not create a breathing issue or a sleep issue. Like, it's not like you go into the surgeon, they take the premolars out and you walk out and you can't sleep that night because you have apnea. What I say is they're not treating the problem, the etiology. You're treating the symptom. So instead, we have to think about this, kind of the converse of this is not does extracting teeth cause an airway problem? It's, does extracting teeth preclude you from addressing the airway problem? Meaning now because we already talked about the fact that if your teeth are that crowded, it's almost always because of deficient jaw size. It's almost never because of large tooth mass. So that patient has deficient jaw size. So if you have this patient who has deficient jaw size and insufficient tongue space and probably a high vaulted palate, right? And all of these other factors, there are numerous studies that talk about the fact that those are signs, and your surgery colleagues obviously see this all the time in these patients with sleep apnea as adults. That's what they look like, right? Most of them, right? Deficient midface and transverse deficiency, high vaulted palate. So by treating the symptom of the crowding, you are not addressing the underlying etiology, and you are setting that patient up for an airway problem to either continue to develop, become, or exacerbate over time, or develop one over time because of the fact you're not addressing and normalizing the anatomy. So no, I don't believe that just pulling teeth causes airway issues. But yes, by pulling teeth, you are avoiding and neglecting the airway underlying etiology of that, which can be it can be associated with airway problem. And then you add, as Jerry Simmons says, add 10 years and 20 pounds to that patient, right, of time and age. And the tissues, as we know, are not as resilient as we age. So you can be taking a patient who maybe has some subclinical signs and symptoms of sleep-related breathing disorder. You're not detecting them. You could send them for a sleep study. Maybe they're fine. But that doesn't mean that they don't have an underlying airway problem. And that doesn't mean that by not addressing that you're not going to potentially be causing that patient harm down the road.
Got it. Okay. That's super helpful. So let's say you get a young patient in and they're, have multiple things saying, yeah, they're getting obstruction and here's some of the issues. You send them to ENT, get the tonsils out, get turbinates taken care of. All these things, but they still have crowding, constriction of the jaws. What's kind of like your next step? I assume you're doing non-surgical things to try to expand things, and then where do you go on the scale of saying, okay, now we've done enough of what we can with ortho, let's go to surgery if we need that. How do you make all those decisions?
Well, I look at it as in Jeff Rouse, who was on my podcast a little while back. I told him, I'm like, Jeff, I'm going to steal this from you. He's a prosthodontist who he teaches for Spear on the airway side of things. And he really understands the airway from young to old and how to manage this. And he said, normalizing anatomy. It was what our goal should be. And I love that because I really feel that what our job is in orthodontics is to normalize anatomy. So unfortunately, a lot of the people who are kind of haters on the whole orthodontics and airway thing make these claims that any orthodontist who sees a value in what we do as it relates to airway and breathing is just expanding to fix the breathing problem, or they're just treating this patient saying it's going to fix their airway. And I've never told a patient that what I'm going to do is going to fix their airway or that I'm curing obstructive sleep apnea or anything of that nature. What I tell patients is and I didn't use this exact phraseology, which I love, wish I had, but normalizing anatomy. I would say, we're going to make your jaws the right width. We're going to make the space for the tongue appropriate. We're going to make the positioning of the teeth more ideal. We're going to help grow the bones in the face to where they're supposed to be. If and when you do that, and you've looked into whether they need allergy intervention and or otolaryngological intervention, and that patient is still struggling, and I can count on one hand the number of times I've ever seen that in young kids, but it's happened. That is when I get a sleep physician involved. That is when we have to start to look at, is there maybe a central cause of this apnea? Is there something else happening in this child's life? Like, what is going on? Because if I have given them normal transverse, if the mid-face deficiency has been addressed, if there's no obstruction in the nasal passageways and no obstruction in the pharyngeal airway, and there's tongue space, I'm not at that point, it's beyond my pay grade and not in my lane to be able to try to be addressing that. But prior to that, I'm addressing any of those abnormalities that I see either directly or through referral to my medical colleagues. And I should mention oral mouthfunctional therapy as well, right? Sometimes maybe you've corrected the anatomy, but they have these habits that are still there. And the OMT can go in, and I have a couple on my podcast, and I'm doing kind of a joint series with Nicole Goldfarb, who's amazing. And we're putting out some airway conversations on this topic because I've learned a lot from them. There's Brittany Murphy's coming on my podcast in a week or two, but because I'm learning from the OMTs as well in this, that, hey, you can normalize the anatomy. And then I saw this a lot in my cases. Sometimes they still tongue thrust, or sometimes they still have open mouth posture, and they need some physical therapy, so to speak, for the mouth to help develop the normal function. But the OMTs will tell you, if you try to do that in an abnormal anatomical situation, you're almost never going to have success, because it'd be like if you have a chronic injury that requires more invasive treatment, trying to just like stretch or do physical therapy of your leg to fix it. Well, no, you're only going to be able to get to a certain point, and then you have a structural abnormality. So they want the structural abnormality fixed, which is what goes in with the ortho and any obstruction of the nasal passageways and pharyngeal airway. Then they can go in and work with the orofacial musculature. And that combination, honestly, Grant, is so effective that, especially if you get them early, that it's rare you will see any of those patients still struggling. As I said, I can count on one hand the number of times I've seen it, and I've seen it, but it is really, really, really rare. And actually, interestingly, to, I guess, kind of bring that full circle, I've had patients come in, both in the residency and in practice, where you see their reports on their airway, their sleep, they're struggling, they're having issues. They've been to the ENT, they've been to the allergist, expect to see, look in the mouth and see these narrow arches and constricted and high vaulted palate, and they're like broad and everything. And I'd say to the parents, like, there's nothing orthodontically that we can do for you. I'm not just going to keep like over expanding you, just trying to, for what? I mean, there's no evidence that works, and it's not making extra room for the tongue than the tongue already needs. I mean, these cases are broad, but again, that is by far the exception. I mean, you will see, maybe one of those in a year that those happen with. It's almost always the first patient I was describing earlier on that I was doing with that resident, that the face presents like that.
Okay. That's amazing. So it sounds like if you catch patients young enough, the vast majority of the time you can normalize the anatomy, and which then will usually eliminate airway issues and potentially eliminate the need for surgical correction of an anatomy that's not normalized, anatomy that's kind of out of whack. I mean, so a lot of questions come out of there, like what ages are we talking about? How old is too old? When do you say, well, we can only do so much with ortho, and now you would need surgery? Can you talk a little about the age component?
Yeah, that could be a whole, we could do a whole hour on that. So I have learned I didn't treat patients much younger than, say, 5 or 6 in my practice. They just weren't coming in to see me. And I certainly wasn't asking for them to come in, because I didn't know at that point that I could even do anything younger, because we're really taught 5 or 6 is most orthodontists don't know 5 or 6 is too young to be doing much more than maybe fix a crossbite. But I have since come to meet, and I actually just had Svetlana Koval. She's an orthodontist down in Boca, Florida, was just on my show recently, and she talked about, Mariana Evans has been on. She's up in outside of Philadelphia. They're going in on 3-4-year-olds, and when they're catching these issues, they're going in young, and they're doing some expansion young on these kids. And when I first heard that, I'm thinking, what's the point? But then when you start to understand the medical literature and the neurocognitive issues that these patients are having, and there's a great study, but Karen Bonnick did a great study in 2012 on this, talking about the behavioral neurocognitive deficits. David Gozal, there's a great study in 2016, looked at 1,010 patients on this, and so that even that snoring alone can lead to significant neurocognitive deficits in these patients. So it's my kid, and they're snoring like crazy, and maybe we get the adenoids out, or maybe there's some, it's rare to have allergy issues that age, but this could happen. But if we're not really obstructed and they're still mouth open and they're growing with this narrow vaulted palate, what's wrong with doing some expansion? I know people who are using Invisalign First for that, or using just some removable expanders. And these kids, Kevin Boyd, he's a colleague of mine. He's up in outside of Chicago, or in Chicago. He's amazing pediatric dentist. I had him on my show, and Kev's great. And he calls 8-year-olds geriatric. He's like, by the time they're 8, they're, you've missed your window. Now, I've fixed a lot of patients 8 years old, but I will give it to him. It's a lot harder. Even 8, 9 years old, you're fighting a lot more. You definitely have a lot more obstacles to try to overcome at that age. So I get it. And these patients, if you can normalize their anatomy younger, then that's kind of the outliers. I do see the profession going that way more, but you can do that. Then the next stage would be kind of the traditional sort of early mixed dentition that most of us think of doing this in. And that was my wheelhouse. That's what I really was focused on. And I would get these patients in, and when their centrals are erupting, usually the lower centrals are in, the lower laterals are blocked typically. The upper centrals are just starting to erupt. The 6-year-old molars are starting to come in, and these patients are super narrow and they're really crowded. And that would be more where I would start them in my practice. And the way you do it in that age group, as I said, I used to use expanders. I just started using braces and wires in these patients, because we know from going back to Ricketts studies in the 70s, the amount of force you need to expand a patient that young, you can get orthopedic change with 221 grams of force, but up to 400 grams of force is certainly acceptable. And nickel titanium wires, 1622 or 1725 nickel titanium thermal wire can certainly deliver 400 to 500 grams of force. So you can get And that's almost a pound is 453 grams. So you can get a pound of force essentially. And that suture, as Melson studies in 75 talk about, it's that infantile suture up until they're 10. So that suture is a wide open highway essentially. And you don't have a lot of interdigitation and it's not technically fusion, but starting to get bony spicules interdigitating at that young age. So I just backed off the force and started doing it with braces and wires. And it was amazing. Now, I don't have courses on it that I teach, but I don't tell everybody you have to do it my way. I just want them in there doing it. So if someone's more comfortable with removable expanders, great. If someone's comfortable with fixed expanders, fine. I did notice that when I went to braces and wires, without blocking the tongue, it let the tongue do a lot more of the work for me. And the tongue started shaping. The tongue is nature's expander, as we call it. It does a lot of that work for you. Whereas when that expander's in there, the tongue can't get up into the palate. So you would take that expander off, and sometimes you'd still have you'd have a wide arch, but it was like still a V shape. You'd kind of have this really wide in the molars. And as you get towards the middle and anterior thirds, it's kind of narrowed in and V'd, and the palate's kind of vaulted a little still. That went away when I went to braces and wires. It just completely went away. I have my technique for it, but I'm just more about get in there, help developing the face. Now, as you get older, to your question of as you start aging, now you get into those teen years, that 10 to 14. That's that Melson calls it the juvenile suture. You start getting that little more tortuous path to the maxillary midline suture, a little more interdigitation. I have colleagues who are going in, and at that point, you start to need more of the rapid force. So if you put braces and wires, you can still get some nice dental alveolar change, but you're not going to get real orthopedic separation of the maxillary suture, midline suture, or circummaxillary sutures. So the typical would be to put an RPE in, right? A fixed expander, and turn it more aggressively once or twice a day to get that real orthopedic change and separation. You can still do the lower lightly. Again, you don't go rapid on the lower, but you would do the upper rapidly. I have colleagues, I've had people on my show who are going in and actually Svetlana Koval's one of them. They're putting Marpies in a lot of these patients, even at 10, 11, 12 years old. Leo Lipkin, another orthodontist, he was on my podcast. He's up in Jersey. He's big on that. He's putting Marpies in these kids younger. He doesn't want the dental side effect that comes with a turnkey expander. So he's got the protocol down, and they're putting Marpies in on these adolescent kids and getting as much orthopedic change as they can get. And one of those things, kind of like with the young kids, I at first was like, geez, that sounds like a lot. But as you think about it anatomically, any orthodontist out there, as I'm sure many of your surgical colleagues, you've seen these cases where you put an expander on a 12-year-old and those molars are just tipped way out. It happens. You get a lot of tipping. We know that. That's why you overcorrect it so it can relapse. And obviously, if you're bone born, especially in that age group, you're not getting that. So that becomes that step. And then as they get more skeletally mature, the mid-teens and older, well, then you need to be doing at that point, you can try with an RPE, and you certainly can get separation sometimes, but it's not super comfortable. But a lot of those patients are doing Marpi now to minimize the dental side effects as well. And then on from there up to, doing Marpi as they get even older from there. I've got some colleagues doing some amazing things with Marpis in these patients in their 20s and 30s and even into their 40s. But that's a whole nother level too, because you're actually, Stanley Liu is a colleague of mine at Nova. He's doing a dome procedure where he's going and making some osteotomy cuts as well to supplement the Marpi. So there's a lot. This is a new emerging part of the field now that I think you're just going to start seeing a ton of in the next 5 years, because everyone's starting to not everyone, a lot of people who are very smart are starting to push that envelope and start to develop newer protocols for that.
Yeah, this is great information to hear about, and hopefully it just the education keeps spreading through our colleagues and thus benefiting our patients. That's probably part of one of the biggest problems, is just educating parents to do this early enough and to get them in the office and get them to the right people. It's just such a huge task.
And on that, sorry, Grandpa, to interrupt, the one thing that on the flip side of that too, and actually I was talking about this with Svetlana when she was on, as their social media and people are seeing my content and other people's content, they then call the orthodontist. Actually talked about this with Jerry Simmons as well, and Steve Carstensen, who was on with him. And we're like, that's hard sometimes, because a parent will call and they'll call 2-3 orthodontists and they're like, your child's too young. There's nothing we can do. And so it's this weird, so you're right. Part of it is getting the parents, because there's the other side where the parents, where you recommend treatment to even a 6-year-old, they're like, what, braces on a 6-year-old? Like, that's too young. And then you have the other side where some of these parents are consuming it in social media, or they hear about it from a friend or a family member who maybe lives in a different area, and they go to their orthodontist, and the orthodontist is like, you don't treat a kid this young. So it's this weird situation we're in.
That was interesting. What would you say or recommend to the oral maxillofacial surgeon who, gets the referral from an orthodontist of a whatever 13, 14-year-old and just says, just like yesterday, this happened to me. It was extract, the referral just says extract 20 and 29. I had this class 3 patient who's got deficient maxilla, and his teeth are all compensating, trying to touch. And they're like, yeah, let's just extract the lower premolars, try to pull those mandibular teeth in more. And yeah, we're camouflaging. It's just like such a not a long-lasting treatment and potentially harmful to the patient. What would you say to the oral surgeon in that position?
Yeah, it's really hard. And having been in private practice for as long as I was, you get it on the ortho side too, where certain patients consult with a colleague on something and come back to you, and it's just so not what you would recommend. And those can be some of the hardest situations to handle, because obviously someone's referring this patient to you, and you might have a personal relationship with them and with the colleague, and it can be really tricky. What I would just do typically, and what I'd advise to the surgeons, is just ask some questions of the parent in that particular case, and just make sure they were educated properly. And if you have concerns in that, contact the referring doc and just say, here are my concerns. And kid's still growing. They are, 14 years old, pulling lower buys. They're already class 3, they've got more growth, a lot more growth potentially with the mandible. We're sure not going to be chasing this later. And now we do this and compensate it and camouflage it, but they grow another differential few millimeters in the mandible, and now it's a surgery case with lower buys out. Now we have a mess on our hands to try to treat this surgically down the road, and just see what they're thinking. So again, if you see, sometimes it's just, you don't notice it till the patient or parent come in, and that's where you can ask them those questions of, did they talk about anything about the potential for the jaw continuing to grow, or a plan for that, and kind of ask those leading questions in the consultation, and then follow up with the colleagues. I'm big on, I always said, if a colleague called me, it's my job to be respectful and hear them out. We can agree to disagree. One of my biggest pet peeves is when you call a colleague and they don't want to hear you out and hear what you're saying and try to think critically about what you're asking them. And to me, that's our professional responsibility. Colleague calls you, and you called that orthodontist and say, hey, just kind of am noticing this, and I want to make sure that before I pull these teeth that we're on the same page, and that this was talked about and this is talked about, and see what they say. And honestly, Grant, there's going to be some times that if they like, oh yeah, we'll figure that out. If they need surgery down the road, and if you're not comfortable, surgeons are going to have to, and I know many who have done this, to say sometimes like, I'm not pulling the teeth. Like we faced that, where I've had people that I train and coach are like, they'll say, they're like, when I talk to some of my surgeon friends and they tell me some stories about this, they'll literally say like they stopped on some of these cases extracting as aggressively for orthodontic space, because they just knew when they went in, they're like, what, the surgeons, you guys know occlusion, you understand this, and you also, I think you have the value that you see these patients when they're older. A lot of times, you not the same patient necessarily, but you see that what was a kid come in at 40, and this patient who is now a surgery case with needing an MMA, and now has severe sleep apnea and all of these other issues. And think of how many of those cases had 4 buys out. And back to our previous discussion, it's not because the 4 buys were taken out, it's because they never addressed the underlying problem when they could have done it with less invasive means when this patient was a child. And I'm not pointing fingers at anybody. 20, 30 years ago, we didn't know what we know now. Now, 10 years from now, I think we can point fingers back to now and say, we should know better. I've been hard on the AAO about this, very hard on them, because I really feel I've challenged people, some of the people in leadership well, and I've challenged them to say privately, like, you need to get ahead of this. Like, you need to start educating our orthodontic colleagues on this more, because we are making decisions just to treat the teeth, which is what they're doing in the case you just described, right? That's totally just treating the teeth. I had many cases like that. I didn't even treat them at 14 when they were like that. I would just tell the parents. Now, if they wanted some aesthetic changes, I would go in or if they needed upper expansion, I'd expand the upper. And because a lot of times those patients have a transverse deficiency, expand the upper, straighten the top teeth, make them look good so they smile well for pictures, and say, we'll keep you on an annual monitoring maintenance program until you're in teens and maybe 20 years old. And at that point, if you want to have a conversation of camouflage or what it involves, we could maybe have that discussion. But again, then taking into account, they have a sleep issue. They're mid-face deficient enough, and this patient is having sleep problems. Well, then you want to, that patient's better off having an advancement of their maxilla than camouflaging those lower teeth just to try to get them to have positive overjet, but now be suffering with a sleep issue. We're not talking like that as orthodontists. We're not even thinking like that. It's really disappointing. And one thing on the AAO white paper, I don't know if you're familiar with the white paper that came out in 2019. And, it's the problem with the white paper. There's a lot of actually good in the white paper. The white paper calls on every orthodontist to screen every patient for airway. So I don't think that's happening. That's like, I know it's not happening. So, a lot of people like to hold on to the white paper and kind of clutch their pearls and say, oh, well, look, the white paper says that the orthodontist has no role in airway management. That is not what the white paper says. The problem that I found with the white paper, as it pertains to children especially, is it focuses on obstructive sleep apnea. So it's kind of predicated on the basis that this child has a diagnosis of OSA, and that if they don't, then there's no problem there. It mentions obstructive sleep apnea 256 times, I think it is. It mentions sleep disordered breathing or sleep-related breathing disorders. I think it's like 12 or something like that, 13. And over half of those are in references and appendices. It's just not focused on the right thing. And I've called on them to put out another white paper that talks about sleep disordered breathing, about the spectrum of disease that is airway disease in children. It's not all about OSA. I've got an article coming out in OrthoTown, I think soon, that talks about that. It's not all about OSA. It's not. We have to start looking at this as a spectrum of disease. So yeah, I would have you encourage your orthodontic colleagues to just get a little more education on that, because a lot of my orthodontic colleagues just look at it and say, well, the AAO white paper said that, there's nothing there, that it's all up to the physician. I mean, a white paper said that if an orthodontist detects an airway problem in a child, we're supposed to refer them to our medical colleagues and then perform treatment only as advised by the physician. I mean, really? We're punting. So now it's our physician colleagues' job to tell us if this patient needs expansion at 7 years old? Really? Like, is that really what we want? I mean, I don't know any pediatricians that want that responsibility to do our job and tell us what to do, or even capable of that. So I look at it, I have to be honest, I think they worry about liability. I think they worry about all these patients that were treated and it was missed on all these years. And to that, I would just say, I don't think anybody, I know no one's I've met is looking to take down orthodontists for this. So I think if they came out ahead of it right now, they could get ahead of it and be like, hey, look, we did the best we could do. We didn't know that this is what was going on. But I think they're going to have a problem if they keep hiding behind this. I think in 10 years, they're going to have a problem, because then they're going to be like, well, wait, circa 2020 or 2020 to 2015, it started becoming known this was more of a thing. You didn't do anything about it. And you were having at your meetings, at the winter meeting of the AAO recently, one of the lectures was on serial extraction. Like, what are we doing? And the morning that they talked about, it was with joint meeting with the AAPD, the morning that they talked about airway, that they devoted to children's airway, was like 2.5, 3 hours the last morning. And it was titled Obstructive Sleep Apnea Diagnosis and Treatment. And I'm like, that's not it. Like, it's not about, why is it so focused on OSA in kids, especially? And again, with adults, it's a different story, but in kids, I just don't understand why we're incorrectly focusing on end stage disease that is very hard to detect in children.
Yeah. One problem too, I think, that is happening, a disconnect or a mistake with the provider and the parents of a patient like this. Story from yesterday is, I feel like oftentimes it's just like, okay, here's the options we have to fix these teeth. 1, extract premolars. That takes X amount of time. 2, jaw surgery. Here's the expense and the time, and their eyes go wide and they're just like, what? Like, we just want straight teeth. Okay, well then probably just extracting premolars and straighten it. Like, that's the discussion. Of course, if you present it like that, a parent is going to say, of course, we're not going to do jaw surgery and years of decompensation and sending them up surgery and then more ortho after that. It's just like, but nowhere in like this patient's and parents' experience, I found out yesterday when I'm talking to them, did anyone even bring up the airway and the super deficient maxilla, and are you having trouble breathing through your nose? All this stuff wasn't even, and they don't know that correcting a jaw position can change the rest of his life as far as breathing goes, and brain function and all this stuff. I feel like we just need to take more time to educate and explain all this, as opposed to just, we move this and the teeth go here, which one do you want, that type of a thing.
It's such a great point, and I agree 110%. And to that point, I had a patient in the residency a couple months back that, prior to me being on faculty there, was treatment planned, and this patient's been in treatment a couple of years, and super class 2 retrognathic, and they were putting some TADs in to anchor the TADs off the anterior teeth with Invisalign to distalize the whole upper dentition. And so the patient comes in, and I looked at her and I noticed the dark circles under her eyes. She was kind of even like dozing, just kind of back in the chair, which for our duration of our appointments, they're not that long. So I sat her up and I said, yeah, mind if I ask you a couple of questions about your sleep and your breathing? She's like, yeah. I started asking her, do you ever tell you to snore? She's like, it's so funny you say that. A couple weeks ago, my husband started saying, you are just snoring unbearably loud. I can't deal with it. And I said, have you been more irritable? She's like, Doc, it's so bad. I'm like so on edge. And I said, are you tired during the day? Your heart waking up in the morning? So all these things. It took 2 minutes to have this conversation with her. And so I said, I'm worried that because your lower jaw is so far back, it's causing you to occlude your airway at night. I said, we have to look more into this. We've got to look up in your nose, and we have to do some more testing. And that's where those patients, I refer to Stanley Liu, who he's an ENT and oral surgeon. He's at Nova with us. So he can start to do his workup, because in an adult, it is different. We need a little more comprehensive workup than in a child. And so I started having these questions, and she's like, well, what would we do about it? And I said, well, the solution would be jaw surgery to get your lower jaw forward to meet your upper, and bring the tongue and help open your airway. I said, the amount of surgery and when and where, like, we'd have to do some work to figure that all out, but that generally speaking. I said, is that something you're open to? And she said to me, why didn't they say this 2 years ago? All I was told is jaw surgery was to fix my bite. No one told me it could change the way I was breathing.
Right. Yeah.
Exactly to your point. Right. Mm-hmm. So here was this patient, and they know the resident, this is a new resident the case was transferred to. I had her go back and look, and they did document, explain jaw surgery to patient declines, but it was explained in the context again of just treating the teeth. And she's thinking, well, if you can fit my teeth together with some little mini anchors in my palate and some Invisalign or jaw surgery, I mean, what are they going to choose, right? But totally missing the fact that now that we're distalizing her upper dentition, we are causing more of a sleep problem, because we're wedging her bite open. She's auto-rotating down and back. It's making her airway worse. It's opening her bite more anteriorly. So, and now she's going to go meet with Stanley and figure out what's going on. So yeah, exactly. So well said. We've got to do a better job educating and having these conversations, because she's open to surgery completely. And she said, I was totally against jaw surgery, but now that I know it can help me breathe better, I'm open to considering it.
Yeah, I love that. So important to have these extended conversations and explain all the pros and cons and educate patients well. Yeah, this has been super enlightening for me. It's awesome that you're working on the orthodontic side of things to help educate and help people be aware of, the whens and hows of fixing the airway and facial structure and growth. It's just awesome. Any other comments about this topic?
One thing I would add is just, again, for the surgeons out there, push your ortho colleagues. Push them to share this episode. I mean, just get them to start to, I have a lot of episodes on my show that we talk about this stuff. Just get them to think differently about it and be educated on it. That's really what we have to do as colleagues, is get each other to think about this more and not just chalk it up to, well, there's nothing I can do about that.
For sure. Totally agree. Well, good. Thank you, Michael. I'll put your contact info in the show notes if you're good with that, and
sure,
links to kind of what you're doing, your site and stuff like that. And keep on casting and changing the world. I love what you're doing.
Thank you. Same to you, and appreciate you doing this and getting the message out and having me on. It's been a pleasure.
Appreciate you. Thanks so much. Have a good day.
Thanks, Grant. You too.
Bye. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and I've been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.